Hello, my name is Amadeus Hornemann. Today I will show you a Burch procedure, laparoscopic Burch procedure, retroperitoneally, an uncut video. So first of all, I make an incision in the umbilicus for my 10mm camera trocar, and then I go with the camera inside this space, and you see I make a little bit space with blunt pushing forward in left and right direction, so I will have enough space for my two instruments. Then I clean the camera a little bit, and you see it's already a good space. Here I made the video a little bit faster when I do something unnecessary for you, for example, bringing trocars inside. That's not so the interesting story. So two instruments are introduced, and now I'm in the right area. There are some blood vessels. I coagulate bipolar and cut with the scissor. And of course it's a little bit limited, this space, but it's, if you are in the right layer, it's very, very easy and fast. So the Burch procedure is much better than the TVT if you do it laparoscopically. A TVT mesh is already forbidden in some countries, for example, United Kingdom. And the big difference to the laparoscopic Burch procedure is that you do the operation with visualization. We use a 3D system that makes it very good with very good visualization. And here I find the right structure already on the right side, and it's the Cooper ligament or ligamentum pectineale. And now I have to operate to open this space. It's just some spider web structure, so to say, only little blood vessels. When I did the classic laparoscopic Burch procedure, I always had to fill the bladder, but in this procedure, when you do it retroperitoneal, you don't have to fill the bladder. It's much faster. You see the spider web. I coagulate just a little bit, and you see the vessels, and I can open this space easy. In the left hand, I always use bipolar grasper, and in the right hand, I use a monopolar scissor. So with both instruments I can cut and I can coagulate. Some of these movements I do blunt, and the others I do with electricity. So it's often a good idea to open it a little bit more. But yeah, that's enough now. So you can see the ligament very good, and here is the foramen obturatorium. Have to be careful with the nerve. The nerve is a little bit more on the right side. So here I continue, open it. Here's a little bit fat tissue going in this foramen. And finally, I have to visualize the bladder. So here I go to the vagina on the right side and mobilize the bladder. The urethra is far away, so you never come in the area to have a problem with this structure. So after the bladder is seen in the vagina too, I put one finger in the vagina there, so that's my left hand, left digital index digit in the vagina, and with the other instrument I move some tissue away from the vagina, and you see there is a cystocele that was on the right side, and now I do the same on the left side. So you can see this finger in the vagina. Of course, from now on you have just one finger left, or one hand left, but that's enough for suturing the vagina. So I introduced a Mercellene suture, a non-absorbable suture. I usually take the number 0 with a sharp needle, and now I suture directly on my finger. That's important, so I can feel and I don't go through the vagina, and now I go through the pectineal ligament. I have just one hand, as I said, so that makes it a little bit more tricky, but yeah, it's possible, as you see. And the nurses help me with making some knots in the end of the suture, so I don't have to suture it there, and I can directly continue. I usually do 4 stitches on both sides, so I can make a lateral repair as well. When you do a TVT procedure, you have just an elevation in the area of the urethra, and here you can suture the vagina and repair the lateral defect. So yeah, with one hand it's not that easy always, but as you see, it's still possible to suture the vagina easily. So never too tight, that's important. If you make it too tight, the patients will have voiding problems. So 2 to 3 centimeters between vagina and the ligament is good. We do it with a running suture. That makes it more flexible. And yeah, now I did 3 sutures in this area on the right side, and now I do the 4th one, and that's enough. So 4th on both sides, and that's the last stitch on the right side. Here you have to be a little bit careful with the vessels. I had 1 bleeding in this area a few months ago, so since then I really be careful, and sometimes I coagulate the vessels in this area. So I remove the finger from the vagina, then I have a second instrument and can make a knot with the suture. So yeah, that's a little bit narrow in this space. You see that sometimes it won't work from the beginning, then you have to do a second knot. But yeah, it's a very fast procedure and the patients are extremely happy. Just little pain, and the operation is one of our favorite because you really can help patients with a severe problem. So that's it on the right side. And as I mentioned already, I use mersilene. That's a polyester suture, and non-resorbable. And then I continue on the left side and do the same on this side. Now it's a little bit faster because nothing is happening. And then I introduce the second suture and put my finger in the vagina again and suture the fascia of the vagina to the ligament on the left side too. It's very rare that it is bleeding in this area. If so, you can coagulate the vessels. It's not a problem. So here you see the ligament. In earlier times, before Burch modified the procedure, the sutures were put into the periost. That made a lot of problems with infection, and therefore it's much better to use the ligament. That's the modification Burch introduced. So again, I have only one hand, and yeah, you have to train a little bit, but if you are able to suture with 2 hands, you will be able to do this with 1 hand too. And the operation usually takes less than half an hour. So in this patient, we needed less than 20 minutes. Sorry. And yeah, patients are extremely happy with this operation. Sometimes they have an voiding problem during the first night, then they get a catheter, but usually it is not possible, not necessary to use this. So I move the bladder to the right side, not to injure it, and here I do the final stitch in the fascia of the vagina, and then I can remove my finger already. Then I have 2 hands, 2 instruments, and of course that makes it more easy to suture the vagina, the fascia, to the ligament. So that's it, 4 stitches on both sides. Now I fix it. Again, the nurse helped me with 4 knots. Yeah, this patient was a little bit tricky, but it doesn't take too much time. So if something like this happens, you have to start again and again. When you make it a little bit wet, it's more easy. And now I fix it, and as I said, it was less than 20 minutes. Of course, you have to do skin suture, and I bend the needle a little bit, then I can remove it through the 5mm trocar. Thank you very much for watching, and if you have questions, please feel free to contact me by email or by telephone.